Hello, friends. Good evening. Welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shonali Chandra, and in today's session, we will talk about the maternal adaptation to pregnancy. And this is the first part of the session today. I have highlighted my reference code here, that is SHONALI. So if you take a plus subscription and subscribe using my code, then you can avail a 10% discount on your subscription package. Unacademy is India's largest learning platform. So if you get a plus subscription, you'll get access to unlimited live and recorded sessions from India's best educators. You'll get daily live classes where you can chat with your educator, ask your doubts and queries and get them solved there and then. So it's like a live classroom experience. The courses are structured keeping in line with the latest NEET PG syllabus. There are also live tests and quizzes on the platform which can help you evaluate your performance as you go along. And most importantly, one subscription gives you unlimited access, so you can watch all of the live sessions from all the faculties who are active on the platform. And even if you miss out on the live sessions, you can always go back and watch the recorded versions from the comfort of your own devices. So top educators are associated with the platform like Dr. Nikita Nanwani, Dr. Mohammad Azam, Dr. Preeti Sharma, Dr. Devesh Mishra, Sir for Pathology, and all 19 subjects which we need to prepare for our postgrad entrance examinations, they are covered on the platform. And every now and then, comprehensive batch courses and even short duration crash courses, they keep getting launched. So you can check out the ongoing courses in the platform as well. And as far as the subscription packages go, you can take, one depending upon your need and requirement. So if you are appearing in the upcoming NEET PG examination and you need a shorter duration crash course, you can take the 3 months or 6 months subscription. And for those of you who are targeting the next year mid-year exams, you can take the 12-month subscription because it will give you ample time to go through all of the sessions and even leave you enough time in the end to revise. And it turns out to be more economical also in the longer run. And if you ask me, for those of you who are wanting a slower pace of preparation, you're still in your final year or third year MBBS and have started preparing, and of course you're juggling, hospital schedules and duties at clinics and classes all together at the same time, then you can take the 24-month subscription. It turns out to be more economical in the longer run. And if you subscribe using my code, that is SHONALI, then you can avail a 10% discount on your subscription package as well, whatever you decide to choose from. So coming back to the session at hand today, where I will be talking about the maternal adaptation to pregnancy. Now, this is a very, very important topic. It is the background of understanding all the complications, all the changes that happen during pregnancy. And I've decided to go ahead with this session in two parts. So in today's part, we'll get an overview of what those changes are, and we will focus on the respiratory system, cardiovascular and the respiratory system changes, and we will talk about the renal system changes broadly, and we will see how questions are asked around the changes that happen. So we're going to focus on some important questions as well. So that is going to be the session for today. Now, when talking about maternal adaptation, I do see that students find this topic a little tougher and, a little towards the side of mugging up and everything. And that's because we have a tendency to isolate the systems and read about it. And what we tend to forget is that, for the 9 months of pregnancy that the woman is carrying the baby, a lot of physiological adaptation and changes that happen in the body are interconnected. So it's not like, a cardiovascular changes will result without changes in the respiratory system. So of course you have to understand that if there's a high BP in a non-pregnant person also, in a non-pregnant woman also, if there's high BP, it is going to affect the cardiovascular system, isn't it? Or if there is low BP, it is going to affect the cardiovascular system as well. So all these systems in our body are actually connected. So you have to understand these changes in totality, and then they start making sense to you. So moving on further, let's start the session for today. So, just giving you a brief overview of what happens during pregnancy is, you can see here that the fetus is growing inside, right? And it is for the entire duration of 9 months that the mother is going to carry this fetus. The fetus is totally dependent on the mother for everything, right? So, for oxygen, for nutrients, for protein requirement, for amino acid requirement, for glucose requirement, for iron requirement, for calcium requirement, everything that the fetus needs, right? The fetus is going to extract it from the mother, and the connecting link is here, the placenta. So the fetus is going to extract all these nutrients from the maternal bloodstream for its own use. Now, to meet the requirements of the fetus, the mother in turn also needs to increase the absorption of glucose, to increase the absorption of fats, amino acids, calcium, and everything that the woman can offer for the baby has to be provided by the mother, and the mother is going to absorb it from her diet as well. So these are the changes that go on. And also important to note here is that the woman takes care of all these changes by laying down these stores of fat and protein, especially in the first half of pregnancy. So deposition of fat and protein stores is built up during the first half of pregnancy especially. And also you can see here that as the fetus grows in size, and the uterus is also enlarging simultaneously, isn't it? So you can see that there is a growth of the uterus that takes place during pregnancy. Now, much of this growth in the later part of pregnancy is because of the stretching of the uterine musculature, because the baby is growing inside. But especially in the first half of pregnancy, or more so in the first trimester, there is myometrial hypertrophy and hyperplasia. So the individual muscle fibers, they undergo hypertrophy and hyperplasia as well. So there's a growth of uterus that is taking place. Also, simultaneously in the 9 months of pregnancy, finally, when the baby is born, the mother has to lactate and breastfeed the child. So obviously there are changes that are undergoing in the breast as well. So there is growth of breasts that happen during the 9 months of pregnancy. There is proliferation and hypertrophy of the ducts and the alveoli, right? So the milk secreting apparatus is built up during the 9 months of pregnancy. Now you can also understand here that when the baby is so dependent on the mother for all his nutritional requirements and for oxygen, considerable blood flow increases into the uterine arteries and to the uterus. So there is an increased uterine artery blood flow that is reaching the uterus, and that is helping to perfuse the placenta. At the same time, the mother also needs to increase the blood supply to her organs also, isn't it? So there's going to be increased blood flow to the growing breast. There's going to be an increased blood flow to the gastrointestinal tract of the mother, so that absorption of nutrients can be done. And simultaneously, the fetus is also extracting a lot of blood from the maternal side. Now, the mother's bloodstream, the mother's system has to perfuse her own requirements of blood as well as take care of the requirements of the baby. So she has to perfuse now two systems simultaneously. It's like two systems are connected in parallel. And for that, obviously, you can understand that there is a massive increase in blood volume that takes place during pregnancy. So blood volume increases consequently because of that requirement of perfusing the placenta, of perfusing the fetus simultaneously. So a considerable amount of blood flows to the uteroplacental circulation via the uterine arteries. Considerable amount of blood flow goes to the breast. Considerable amount of blood flow goes to the kidneys of the woman. So all of this simultaneous perfusion will take place if the blood volume increases. Now that's very important point to note. Now the other important aspect is you realize that every process which I have described here, the growth of the uterus or the growth of the breast, or the absorption of nutrients or the transfer of nutrients, all of these are energy driven processes, isn't it? They are energy driven processes. They require oxygen, they require ATP, and for that reason you will realize that the basal metabolic rate in pregnancy increases. Now when the basal metabolic rate in pregnancy increases, the another important factor to note here is that the thyroid hormone production, the thyroid hormones are closely linked and are required to increase the basal metabolic rate. So to meet that increased requirement of basal metabolic rate, the thyroid hormone production also increases in pregnancy. Another very, very important point to note, right? So the thyroid hormone production increases because of the thyroid gland hyperplasia that happens during pregnancy, and that helps to increase the basal metabolic rate by about 20% at term. So that is the amount of increase in basal metabolic rate that happens. And like I told you, these are energy driven processes, so they also need oxygen, isn't it? So the oxygen consumption in the mother also increases during pregnancy. Oxygen consumption also increases. Now if I want to consume more oxygen, right, if I want to remember more, if I want to consume more oxygen, then I will also have to breathe in more oxygen, right? So to be able to breathe in more oxygen, it will be the respiratory system, it will be the lungs which will take care of those changes, isn't it? So then we are going to talk about the respiratory changes in pregnancy. We'll figure out how the oxygen consumption or how the breathing in more of oxygen happens during pregnancy. Now, of course, consuming oxygen or breathing oxygen is by alone itself not enough. That oxygen needs to be transported as well. And the oxygen transport happens by the bloodstream, isn't it? So the oxygen transport also increases. The oxygen carrying capacity of the blood also increases. Now, what is responsible for carrying oxygen in the blood? It is the hemoglobin, isn't it? That hemoglobin is present in the RBCs. So if there is a requirement for increasing oxygen carrying capacity of blood, simultaneously the RBC mass also increases in pregnancy, right? So we see two important blood changes here. The blood volume increases and the RBC mass also increases in pregnancy. Right? Now let's move on further and let's talk about what happens because of these changes. Now what I want to point out here is one important fact, that you should remember that whatever physiological changes that are happening in the woman's body, they are in anticipation of carrying pregnancy to term. They are in anticipation of the changes that are going to take place after delivery also. So after delivery of the baby, what will happen is that this placenta will be expelled. And then every delivery, no matter if it takes place vaginally, no matter if it takes place by cesarean section, whatever be the mode of the delivery, every delivery is associated with some blood loss, isn't it? It's inevitable. So blood loss is going to take place after delivery, and what the woman's body has to ensure is that bleeding should stop after the delivery of the baby and the placenta. Now to ensure that, one of the reasons that bleeding stops after delivery of the placenta is that the uterus contracts, and that is a very important reason for the blood to stop after delivery. But yes, of course, the clotting factors which are required to clot the blood, they also increase in pregnancy. Now all clotting factors, they tend to increase in pregnancy except for factor number 11 and 13. In fact, fibrinogen increases by about 50%. Fibrinogen increases by about 50%, making pregnancy a very hypercoagulable state. Now, on one hand, I'm saying that the clotting factors are increasing. On one hand, I'm saying the RBC mass is increasing. So does that mean that the blood is becoming thicker? Because often we associate venous stasis and sluggish blood flow with coagulation, don't we? So that is a downside of this increase in clotting factors and RBC mass. Now that has to be counteracted. we don't want the blood to become thick in pregnancy. We don't want to add to the already hypercoagulable state of pregnancy. And moreover, the blood flow through the placenta has to increase, to the uterus has to increase, to the various organs, the blood flow has to increase. So we need the blood to flow faster, isn't it? So we need a thinner blood. And that is what is achieved in pregnancy. So what is achieved in pregnancy is what we call as hemodilution, right? So why does that happen? Because yes, no matter the blood volume increases, no matter the RBC mass also increases, but the plasma volume, another component of blood. What is blood? Blood is made up of the cells, the RBCs, the leukocytes, the clotting factors, and plasma. So the plasma volume increases much more. Plasma volume increases much more in comparison to the RBC mass. If you talk about in percentages, RBC mass increases about 20 to 30%. Plasma volume increases about 40 to 50%, making the increase in blood volume about 30 to 40%, right? So we see that the plasma volume increases much more in comparison to the RBC mass, and that contributes to hemodilution in pregnancy. And this hemodilution is very protective. This is protective in pregnancy. Why is it protective? Like I explained to you, it keeps the blood flowing. Okay, and the other reason why hemodilution is protective, look at this diagram here and see, it is just a diagrammatic representation to show you that in per unit volume of blood, there is more of plasma and less of RBCs, even though the RBC mass or RBC number in totality has increased. And then on the other hand, there is another diagram here showing you what if this hemodilution had not been achieved. What if this hemodilution had not been achieved, or let's say this was hemoconcentrated, okay? Then imagine if there was a loss of 500 ml of blood. If I would take 500 ml of blood from this blood volume which is hemodiluted, and if I were to take 500 ml of blood from this blood volume which was hemoconcentrated, which system will lose more RBCs? Which system will lose more RBCs? So it is clear to see that even though equal amounts of blood are lost from system number A and system number B, but system number B would lose more RBCs for the same amount of blood loss, whereas system A would lose less RBCs. Right? So hemodilution offers a protection against loss of RBCs also when eventually after delivery blood loss is going to happen. A woman who is properly hemodiluted will lose less of RBCs, so is going to be protected against blood loss, whereas a woman who is going to be hemoconcentrated will lose more of RBCs and is not going to be protected against blood loss, which is bound to happen during delivery. So one of the prime changes that take place in the maternal system is increase in blood volume, increase in RBC mass, and much more increase in plasma volume as compared to the RBC mass, contributing to hemodilution in pregnancy, which is a must requirement for a healthy pregnancy. It allows for the blood to flow rapidly. It also allows for the prevention of blood loss after delivery. Generally, what is the amount of blood loss during normal delivery? On an average, it's about 500 ml. Anything which is more than 500 ml is considered more, and in a C-section the normal amount of blood loss is about, on an average, 800 to 1000 ml. So anything that is more than 1000 ml in a cesarean section is considered as excessive blood loss. Okay, Janani, right? Now, moving ahead further and talking about a discussion further, I want to also emphasize on one point, that how does this plasma volume increase in pregnancy? What is plasma? I told you that blood minus the clotting factors minus the RBC mass is all plasma. So what is in the plasma? Plasma is mostly water. Plasma is mostly water. So if a woman wants to increase her plasma volume, she needs to retain more water, and that is exactly what happens in pregnancy. This blood volume that increases is mainly because of water retention in pregnancy. Water retention increases in pregnancy, right? Very important point to note. A lot of water is retained during pregnancy, right? So the blood volume from being 5 liters on an average in a non-pregnant woman reaches about 8 liters. That's a considerable amount of blood volume. And what is contributing to that? Increased water retention in pregnancy. Now, how can you and I, if you and I want to retain more water in our body, how would we go about doing that? How will be that brought about? One thing is we can drink more water, right? We can keep drinking more water. That would lead to water retention. The other thing is that the kidneys will retain water for us. It is the kidneys which excrete water out of the body. So if water needs to be retained, again, it is going to be the kidneys which are going to take care of water retention, right? Now, you and I, when somebody is not pregnant, we drink water as and when we feel thirsty. Isn't it? We drink water as and when we feel thirsty. Now, it has to be ensured that the woman drinks more water. For that, a woman will start feeling thirsty more, right? So let's say, for example, and this is just a hypothetical point that I'm making, the numbers that I'm using are hypothetical. Let's say, for example, that I feel thirsty in the non-pregnant state when my plasma osmolality, all the thirst is governed by the plasma osmolality. So when I'm thirsty, the plasma osmolality, let's say, is somewhere at 50 points. Okay, so then when my plasma osmolality reaches a concentrated 50 points, I start feeling thirsty and I drink water to quench my thirst and increase the plasma osmolality. Now, in pregnancy, what will happen? A woman will start feeling thirsty at a lower threshold. She might start to feel thirsty at 30 points of plasma osmolality only. Right? So what has happened? She starts feeling thirsty at lesser levels of plasma osmolality itself. And this is what they mean when they say that the osmotic threshold for thirst decreases. Okay, this is what they mean when they say that the osmotic threshold for thirst decreases, and the plasma osmolality also decreases in pregnancy. So again, very important points. Why the water retention happens is because of a decline in plasma osmolality, because a woman will start getting thirsty at lower plasma osmolality threshold, so the osmotic threshold for thirst also decreases, right? And then, yes, the kidneys are going to directly contribute to salt and water retention. So when water is retained, simultaneously sodium and potassium is also retained. Both sodium and potassium are retained in pregnancy, but yes, the water retention is much more in comparison to salt retention, right? So keep that in mind also, that both water and salt are retained, but water retention is much more in compared to salt retention, right? Now, why do the kidneys go for salt and water retention? Why does that happen? Actually, it is estrogen related effect. Estrogen causes direct stimulation of the renin-angiotensin system. So when estrogen causes direct stimulation of the renin-angiotensin system, the kidneys get activated to increase its retention of salt and water. Now you can counter argue with me, and you should counter argue with me and say that if angiotensin is increasing, then the blood pressure should rise. Now see, the physiological changes of pregnancy are in fact physiology of contradictions, if I may tell you so. So yes, you can argue with me that on one hand, ma'am, you are saying that salt and water need to be retained, for that renin-angiotensin system gets activated. Okay, so far makes sense. But you can argue that if angiotensin is increasing, then the blood pressure should also rise. But that doesn't happen in pregnancy. Mind you, that doesn't happen in pregnancy because of another hormone which is coming from the placenta. That's progesterone. Now, this progesterone causes vasodilatation. This progesterone causes angiotensin refractoriness. It causes angiotensin refractoriness of the blood vessels. to the effects of the pressure action, or the increasing in blood pressure will not happen, because progesterone is contributing to vasodilatation and leads to angiotensin refractoriness of the blood vessels, right? So this vasodilatation which is happening during pregnancy, and this vasodilatation is not only an effect of progesterone, but hormones like estrogen, hormones like relaxin, and local release of nitric oxide at the level of the blood vessels, endothelial cells, all of this together contribute to causing vasodilatation in pregnancy. And all that vasodilatation causes a decrease in peripheral vascular resistance, isn't it? So the peripheral vascular resistance is going to fall because of the vasodilatation, right? So peripheral vascular resistance, systemic vascular resistance, this falls, right? So all this extra blood volume from 5 liters to 8 liters, where is this blood volume circulating in the body? It is circulating in the venous system, it is circulating in the arterial system, right? And you know that the venous vessels are called as the capacitance vessels. They're called as the capacitance vessels. They can dilate, they can accumulate and increase their capacity and hold large amounts of blood volume, isn't that right? So the peripheral vascular resistance, the systemic vascular resistance, it decreases, and that contributes to a decrease in blood pressure in pregnancy. Very, very important point. So what increases? Blood volume increases. What increases? Water retention increases. What increases? RBC mass increases, plasma volume increases. But do not say that blood pressure increases in pregnancy. Blood pressure falls in pregnancy because of the peripheral vascular resistance, which decreases in pregnancy, and that's because of the pregnancy hormones which are causing vasodilatation. Right? Now, the other thing that happens because of these changes, because of this peripheral vascular resistance declining, is that there's a lot of peripheral pooling of blood, isn't it? Woman walks around, gets up for bed, standing and walking around during daily activities. So there's a lot of peripheral pooling of blood that happens in the peripheral venous vessels. So that all contributes to a physiological edema in pregnancy. That's something that is very, very normal, right? So you can also understand that when the woman lies down, takes rest, limb elevation and everything, all that will reduce the physiological edema of pregnancy. So it is something that is a transitory. It occurs more so during the daytime, and then it subsides after taking a period of lying down, after taking period of rest. Okay, so these are some of the important changes in the blood volume, blood pressure and water retention which you need to keep in mind, right? Now let's focus on the cardiovascular system changes. Now all this increasing blood volume is happening. The blood needs to be pumped forward for the placenta, for the breast, for the uterus, for all of these organs of the maternal system. So obviously the heart takes care of that, and the cardiac output increases in pregnancy. The cardiac output increases by about 40 to 50% during pregnancy. That much increase in cardiac output takes place, right? The heart rate also increases. So cardiac output is the the amount of blood that the heart is pumping in a minute, isn't it? That is what the cardiac output is. So the heart rate, so basically cardiac output is a product of your heart rate into the stroke volume. Heart rate, the number of heartbeats per minute, and stroke volume is the amount of blood that is being pumped in one heartbeat, right? So both the heart rate and the stroke volume, they also increase in pregnancy. So the heart rate increases by about 20% in pregnancy. Stroke volume also increases in pregnancy. So all of these cardiovascular system changes, they are increasing, mind you, they are increasing. Now in NEET PG, you also need to remember what doesn't change. So what doesn't change is the ejection fraction. Please remember that the ejection fraction does not change, it remains the same, right? Please remember that the central venous pressure, that also remains the same. So in NEET PG, you also need to remember what are the factors, or what are the points that remain the same, what are the features that remain the same in pregnancy. So do not forget that as well. Now, moving on further, let's have a look at this question. I'll just have to erase this part here. Okay, let's have a look at this question, see how they ask the question in your exams. So have a look. There's a 25-year-old private gravida with mitral stenosis. She has a heart disease. She has a heart disease, mitral stenosis, and she's pregnant. When is her risk of going into heart failure maximum? What is your answer to this question? Is it at 32 weeks? Is it during labor? Is it immediately after delivery? Or is it at term? When is the risk of going into heart failure maximum? You should understand that the risk of going into heart failure during and around pregnancy is going to be maximum when the cardiac output is going to be maximum, isn't it? So even if they ask you when is the risk of going into heart failure maximum, they are actually asking you when is her cardiac output maximum. So when is the cardiac output maximum? Yes, Janani rightly said it's immediately after delivery. So please remember that the cardiac output starts to rise. The cardiac output starts to rise by about 5 weeks of pregnancy, and then it continues to rise. It continues to rise and it reaches a maximum during a time when the blood volume is also maximum. During the time when the blood volume is also maximum, and that's somewhere around 32 to 34 weeks. That's when the cardiac output is maximum in the antenatal period. But during delivery, in the intrapartum period, there is a further increase. There is an additional increase of about 50% in the cardiac output with each uterine contraction. So during the delivery, during the intrapartum period, when the uterus contracts, with each uterine contraction, an additional 350 to 500 ml of blood seeps back into the maternal circulation. So if that extra blood seeps back into the maternal circulation, that increases the venous return, that increases the venous return to the right side of the heart, and that increases the cardiac output consequently. So in intrapartum period, there is an additional increase in cardiac output 50% with each uterine contraction. And then immediate postpartum. In the immediate postpartum period, there is further additional increase of about 80% in cardiac output, because now the placenta has been out in the postpartum period after delivery. Once the placenta is expelled, the uterus forcefully contracts back, and then another extra amount of blood seeps back into the maternal circulation, and that further increases cardiac output. So whether they're asking you when is cardiac output maximum, or whether they're asking you when is the risk of going into heart failure maximum, they're asking you the same things, right? So when is the cardiac output maximum or the risk of going into heart failure maximum? In the immediate postpartum period. Then in the intrapartum period is the second at-risk point. Then around 32 to 34 weeks is another at-risk period. So keep these important pointers in mind. Cardiac output and cardiovascular system changes are often asked in your NEET PG examinations. Okay. Now, moving on further, what are the physical changes in the cardiovascular system? And these are important to know because a number of these physiological changes can be confused with heart disease findings. Okay, and that's why it is important to know what are the physiological changes in the physical examination findings, and that will help you to understand what is pathological, because many times the cardiovascular changes in pregnancy, they can be confused with heart disease findings. So let us see what those changes are. You can look at the inset. There's a figure I'm showing. So as pregnancy advances and the uterus goes bigger in size, it is going to push the diaphragm up. When the diaphragm is going to be pushed up, this is the diaphragm here, this diaphragm is going to be pushed up. That is going to cause lifting of the heart, right? So the heart is lifted and slightly, it is lifted up and out. So please remember that the heart is lifted up and out. Okay, so normally one auscultates the apex beat. Normally one auscultates the apex beat at the fifth intercostal space medial to the mid-clavicular line. But in pregnant women, the apex beat shifts to the fourth intercostal space. So from the fifth intercostal space, it has shifted up to the fourth intercostal space, lateral out. Okay, from being medial to the mid clavicular line, it has shifted lateral to the mid clavicular line. Another important change that happens is that sometimes it can be felt that the left heart border is slightly more straightened. So there can be straightening of the left heart border. There can be loud heart sounds. Because why loud heart sounds? Because as the cardiac output is increasing, as the stroke volume is increasing, more blood is flowing across the walls. Right? So when more blood is flowing across the walls of the heart, it is reflected as loud heart sounds on auscultation of the heart. So that there can also be an exaggerated splitting of the first heart sound. There can also be an S3 that can be heard sometimes because of the turbulent flow of blood in the heart. And there can also be an ejection systolic murmur, but that ejection systolic murmur is going to be only up to grade 2. So it can be grade 1 or grade 2, not more than that. So these are your normal physical changes, physiological changes during pregnancy. So you need to remember this because they do ask you in MCQs. They will give you options. They will say you all are physiological except. So they want to know what are the abnormal changes. What are the changes if you find you will think of heart disease in pregnancy. So please remember that straightening of left heart border is normal physiological change, but any cardiomegaly is abnormal. Any cardiomegaly is abnormal. Exaggerated splitting of S1 is considered physiological, but a split second heart sound is not normal. S3 is considered normal, but an S4 if heard is not normal. Ejection systolic murmur up to grade 3 is considered physiological, but an ejection systolic murmur that is grade 3 or more is not considered normal. Any diastolic murmur of any grade, any diastolic murmur is not considered normal. Any increase in jugular venous pressure is not considered normal. So these are the abnormal changes. These are considered abnormal. They are not normal physiological changes. So keep that in mind as well. So yes, they have asked you this question in exams. Which of the following cardiovascular changes is abnormal in pregnancy? Now let's see who answers. Enlarged cardiac silhouette, increased splitting of S1, right axis deviation on ECG, or loud heart sounds. Which of the following is abnormal in pregnancy? Now, I have not given you the answer straight away when I described you the changes in the previous slide, but still, even with the information that I have provided to you, try to answer this question. Yes, very good, Vandana. Right axis deviation is abnormal in pregnancy. Very good, Rashmi. So the heart moves up and out. So there can be a slight left axis deviation, isn't it? So there can be a slight left axis deviation. It is not going to be marked, mind you, it is going to be only a slight left axis deviation, somewhere around, about at the most 20 degrees left axis deviation. So slight left axis deviation is normal physiological, but any right axis deviation is definitely abnormal, right? Okay. So yes, Dr. Satyendra, you also answered and got it correctly that right axis deviation on ECG is not normal. Now let's move ahead and have a look at another question. Let's see who answers this. A woman was referred from the peripheral healthcare center with prolonged labor. She is now being taken up for cesarean section for fetal distress. Which of the following is the correct position in which the nurse should keep the patient on the OT table? It's a very practical question. Was asked in the AIMS examination 2 years ago. Right? The answer to this question also lies in understanding the physiological changes of pregnancy. A woman has been in prolonged labor. She must have been lying down supine position for a long duration of time. When a woman lies down long duration in the supine position, what happens because of that? What happens because of that? There is supine hypotension syndrome, isn't it? There is supine hypotension syndrome that a woman will complain of, especially near to term, because the gravid uterus, right? The uterus is now big in size, and that uterus, which is slightly dextro-rotated, slightly tilted to the right side, that big uterus that is slightly tilted to the right side is going to put compression on the inferior vena cava. Right? Inferior vena cava compression. And this is going to be more in which position? In the supine, lying on the back, in the supine position. And that inferior vena cava compression is going to cause a decreased venous return. It is going to cause a decrease in cardiac output, isn't it? So, there is a supine hypotension. This leads to supine hypotension. Now, I'm taking up this woman for cesarean section. I want to avoid sudden blood pressure changes during the cesarean section. So, the best possible solution is that tilt the woman slightly to the left side. Right? Now, in an OT table, yes, we do have the OT tables which can be shifted and tilted altogether. So, this upward tilt can be done. Tilt from the right side up. Now, if that OT table is not there, then one can have a supine position and then place a wedge under the right hip. If one does that, then the compression on the inferior vena cava is relieved because the right hip is lifted up, consequently the uterus is lifted up, and then the compression on the inferior vena cava is relieved. So what is the best position? What is the correct position? Yes, supine position with a wedge placed under the right hip to relieve the inferior vena cava compression. So all of you got it right. Good. Mariam, Janni, Vanda and Satyendra rightly said supine position with a wedge under the right hip. The reason why we're doing this is to avoid inferior vena cava compression, which can lead to hypotension, and I want to avoid hypotension during cesarean section. Okay? Right. Now let's move on to the next system. Let's talk about the respiratory system changes. Now, what are the respiratory system changes? So like I told you that a woman needs to breathe in more oxygen. Oxygen requirement increases during pregnancy. So for that, one has to breathe in more oxygen. Now, you have seen pregnant women around you. You have seen pregnant women in the OPDs. Now, how are they sitting in front of you? Are they sitting comfortably like you and I are sitting, or are they breathing very heavily? Until unless they are diseased, of course, until unless they have a lung disease or a heart disease, they are not being dyspneic at rest, they are sitting comfortably. So what do we figure out from that? The important thing to figure out from that is that the respiratory rate remains the same. The respiratory rate remains the same during pregnancy, does not increase, does not decrease. So if the respiratory rate remains the same, how will you ensure that you breathe in more oxygen? Breathing at the same rate, how will you ensure that you take in more oxygen, breathe in more oxygen? By taking deep breaths, isn't it? By taking deep breaths, by hyperventilating. So what are you doing? In one breath, you are breathing in more air. So that is what we call as tidal volume. That is what we call as tidal volume. So tidal volume increases in pregnancy. The woman is taking deep breaths. Right? Now, if the amount of air that one breathes in one single breath increases, obviously the amount of air that one breathes in a single minute also increases. So the minute volume also increases in pregnancy. Isn't it? So the respiratory rate remains the same. You remember this. Remember that the oxygen requirement by the body is increasing in pregnancy, and to take that, the woman needs to breathe in more air. And that is going to be accomplished if the woman takes deep breaths. So the tidal volume increases, the minute volume also increases, and the inspiratory capacity. The inspiratory capacity also increases in pregnancy. Keep that in mind as well. The inspiratory capacity also increases. So What remains the same? Respiratory rate, tidal volume, minute volume, inspiratory capacity all increase in pregnancy. So what decreases in the respiratory system changes? All the expiratory volumes, they decrease in pregnancy. So you can see here on the inset I've provided you the diagram here, and again I'm showing that when the uterus becomes too large, it pushes the diaphragm up. Can you see? This is the original location of the diaphragm. The diaphragm is pushed up. By about 4 centimeter. Now that causes a restriction on the thoracic cage and the movement of the thoracic cage, not the movement of the lungs, mind you, but movement of the thoracic cage. So the movement of the thoracic cage is restricted. The space here in the thorax is also restricted, because you can see here that the subcostal angle also increases in pregnancy as the pregnancy advances. So all of these factors combine to cause a restriction on the movement of thoracic cage, and that decreases the expiratory volume. So the residual volume decreases in pregnancy. So does the expiratory reserve volume, the functional residual capacity. All of these, they decrease in pregnancy. But the total lung capacity actually is either slightly decreased or it remains the same. The total lung capacity is slightly decreased or it remains the same, and the vital capacity also remains the same. So important point to remember: what increases, like I told you, tidal volume, minute volume, and the inspiratory capacity increases. All the expiratory volumes, like the residual volume, expiratory reserve volume, and functional residual capacity, they decrease in pregnancy. And the total lung capacity and the vital capacity, they remain the same in pregnancy. Okay, so let's see what questions they are asking. Let's see how they're asking the questions in the exams. Now answer this. All of the following statements regarding physiological changes in pregnancy are true except. What is not true? Increased cardiac output, true or not? Increased tidal volume, true or not? Unchanged lung compliance, true or not? And increased respiratory rate, true or not? So what is not true? All are true except. What's the answer to this question? Yes. Yes, Janani has the first one to answer. Yes, increased respiratory rate. Increased respiratory rate doesn't happen in pregnancy. Respiratory rate remains the same, like I told you. So cardiac output increases, yes. Tidal volume also increases, yes. The lung compliance. So what does lung compliance refer to? Lung compliance means the ability of the lungs to expand and deflate. That doesn't change in pregnancy. If that would have changed, then it would have been impossible to take deep breaths. Okay, so the lung compliance doesn't change in pregnancy. This is also true. What is not true is that the respiratory rate increases. That's not true. Respiratory rate, like I told you, remains the same. So you can understand that if you remember the basic pointers, what I'm trying to hint from this is, if you remember the basic pointers, you can always eliminate the wrong options. You can always come to that. Because even if you had no idea about the lung compliance in this question, one thing that you need to be certain of is that the respiratory rate remains the same. So there's your answer, isn't it? So in many times in examination, especially when choosing from the multiple choice questions, it really helps to eliminate options, right? So it doesn't matter if you have to remember all of the pointers, but you have to remember the key pointers to help you attempt such questions in your exams. Okay. Now, moving on further, let's take up this question. The following physiological changes occur in pregnancy except increased subcostal angle, hyperventilation, decreased residual volume, and metabolic acidosis. What doesn't happen in pregnancy? Okay, so the following physiological changes occur in pregnancy, except what doesn't happen in pregnancy. Increase in subcostal angle. I just showed you the slide. Yes, the uterus, when it enlarges, it pushes the diaphragm up. That increases the subcostal angle as well. So this is true. Woman is taking deep breaths. Hyperventilation. That's true. Decreased residual volume, the expiratory volumes, they are decreased. That is true. Now you should also understand metabolic acidosis. If you will take a blood sample from a pregnant woman and measure her pH, will she be acidotic? Does she look to you acidotic? Why will she have metabolic acidosis? She is hyperventilating. When a woman or anybody, you, me, anybody, pregnant, non-pregnant, when we hyperventilate, we breathe in more oxygen, true, but we also breathe out more carbon dioxide, don't we? So whenever there is hyperventilation, there is carbon dioxide washout as well. And that creates a respiratory alkalosis. That creates a respiratory alkalosis. Now, this respiratory alkalosis is compensated. It is compensated. Who is going to compensate for this respiratory alkalosis? The kidneys are going to compensate for this respiratory alkalosis. So there is no metabolic acidosis in pregnancy. Please, that is the correct answer here. So metabolic acidosis does not occur. If at all there is a slight compensated respiratory alkalosis, it gets compensated. Why? Because the kidneys to compensate for this respiratory alkalosis, they absorb more bicarbonate. The kidneys, they absorb more bicarbonate to compensate for this respiratory alkalosis. So the answer here is option number D. Metabolic acidosis is something that is not physiological in pregnancy, right? So yes, with the upcoming NEET next and NEET pattern questions, we are expecting a comprehensive questions. So we are asking about physiological changes in pregnancy, but then we have also included the aspect of alkalosis and acidosis in the question. So it tests your knowledge of obstetrics and pregnancy, as well as tests your knowledge about the metabolic derangement that arises because of hyperventilation, right? So keep this in mind as well, that such kind of comprehensive questions are going to be asked more often in the upcoming exams, right? So let's move forward and now talk about the renal changes. So one of the renal changes I gave you, that it compensates for the respiratory alkalosis, but that said and done, there are also other significant renal changes that take place in pregnancy. So what are those renal changes? So one thing that you must have noticed in pregnant women is, and that they are often very troubled with that complaint, is कि बहुत बार उनको यूरिन बार बाथरूम जाना पड़ता है. Their complaint is that they are suffering from, they are having increased frequency of micturition. They are so troubled that, they have to get up 1 or 2 times after going off to bed also. At night also they have to get up and pass urine 1 or 2 times. So nocturia and increased frequency of micturition, they are very bothersome complaints for the woman. Now, why does that happen? Why is there an increased frequency of urine? More urine is getting formed. Yes, I agree. But how? Why? The fact is that there is an increased renal blood flow during pregnancy. Renal blood flow increases. Renal blood flow increases during pregnancy. In other words, when the blood flow to the uterus is also increasing, blood flow to the breasts is also increasing. There's vasodilatation everywhere. Okay, so there is increased blood flow reaching to the lungs as well. There is increased blood flow. A woman sometimes complains of that palmar erythema and that warmness of the hands because of increased blood flow in the cutaneous circulation. So similarly, there is increased blood blood flow in the renal system also. So renal blood flow increases. When the renal blood flow increases, more filtration also occurs across the glomerulus, right? So the glomerular filtration rate also increases. So renal blood flow increases, the GFR increases in pregnancy. When that happens, you see, remember that there is increased creatinine clearance. More creatinine is going to get filtered out. If more creatinine is going to get filtered out, what will happen to the serum creatinine concentration? The serum creatinine concentration is going to decrease in pregnancy. So for a normal person, the range of serum creatinine is maybe 0.8, 0.9, 1 milligram per deciliter, fine. But in pregnant women, you measure the serum creatinine, their values are 0.6, 0.7, 0.8. So the serum creatinine concentration falls in pregnancy. Similarly, uric acid excretion also increases, and serum uric acid also decreases in pregnancy. Keep that in mind. And next, importantly, that the renal excretion of glucose also increases. So glycosuria is also a normal physiological change in pregnancy, right? Now, because of this increased renal blood flow that is happening, the kidneys, they slightly appear larger in size. So there is an increase in size of the kidneys. There is an increase in size of the kidneys by about 1 centimeter. All right, there's a slight increase in size of the kidneys. The another important factor to note here is that progesterone causes dilatation of the smooth muscles, right? So progesterone was causing dilatation of the smooth muscles of the blood vessels. Progesterone also causes dilatation of the smooth muscle of the ureter. So that leads to hydroureteronephrosis, isn't it? That used to hydroureter. This is what we call as hydroureter. Now, it is often asked in exams on which side the hydroureter is more. Is it more on the right side or is it more on the left side? On which side the hydroureter is more? Is it more on the right side or is it more on the left side? Well, as pregnancy advances and the uterus becomes too large in size, uterus is slightly dextrorotated, shifted to the right side. So more compression on the right-sided ureter. Okay, so that's why the hydroureter is more on the right side as compared to the left side. Right? So this is also a direct MCQ that they have asked in the exams, right? So hydroureter happens because of progesterone related smooth muscle dilatation of the ureter. So it can happen on both sides, right and left as well. But it is more commonly seen on the right side because of compression of the ureter from the dextrorotated uterus. Alright, now what do we see? I told you that all this increase in renal blood flow GFR causes an increased frequency of micturition. It causes nocturia in the woman, right? All this hydroureter on top of that happening, right? It is going to lead to stasis of the urine. It is going to lead to urinary stasis. Right? So this urinary stasis that happens in pregnancy predisposes to UTI, predisposes to urinary tract infection. So pregnant women, they are more prone than non-pregnant women to get urinary tract infection. That's a very, very important point to note. And that's why we have to always check for urine routine microscopy and culture during pregnancy. It's a routine investigation. Why is it such a routine investigation? Why do we want to check for bacteria in the urine in pregnant women? Because there is urinary stasis, because there is predisposition to UTI. So if the urine of the pregnant woman is harboring bacteria, if the urine of the pregnant woman is harboring bacteria, even if she has no symptoms of urinary infection, asymptomatic bacteriuria, if it is there, then because of this stasis and everything, what can happen is that there can be increased predisposition to ascending infection. So, like if a non-pregnant woman has UTI, she will take the medication, she will drink enough water, and the urine will get cleared of infection. But in a pregnant woman, if she has UTI, if she has asymptomatic bacteriuria and she doesn't get treated, then the infection can ascend upwards towards the kidneys more often. So that is a very, very important change to remember. The clinical aspect of that is this changes is that there is an increased predisposition to UTI even with asymptomatic bacteriuria, if not treated, can ascend upwards to the kidneys and cause infection of the kidneys. Okay. Now let's see what kind of questions they have asked. Look at this question now. The following changes occur in the urinary system in pregnancy except increased GFR, increase in renal blood flow, hypertrophy of bladder musculature, and increased activity of the ureters. So I have purposely in my questions included one or two options here and there about which we tend to not have an idea about, because what I want to point out is that this is a chapter where there is loads to study, but what I want you to remember is remember the most important changes, and most of the times you will come out with the right answer. So Janani is attempting, she's saying increased activity of the ureters, and I totally agree with her, because the ureters are having decreased activity. There is decreased peristalsis because of ureter dilatation. There is ureteral dilatation. There is smooth muscle relaxation of the ureters. So how the activity of ureters is going to get increased? Okay, so there is decreased activity of the ureters, there's decreased peristalsis, increased GFR, true, increased renal blood flow, true, and yes, some hypertrophy of bladder musculature is also seen in pregnancy. That's also a true statement. Okay, clear? Now let's move ahead and talk about another question. Let's see this. All of the following predispose to urinary tract infections in pregnancy except urinary stasis, diabetes, vesicoureteral reflux, and hypertension. Now, this is a plain, straightforward question. You don't even need to know obstetrics to be able to answer this question. All of the following predispose to UTI in pregnancy except urinary stresses will contribute to increased urinary tract infection. Diabetes by itself, when there is going to be excess of glucose excretion in the urine in a diabetic person, that increases the risk of UTI. When there is vesicoureteral reflux, that also increases the risk of UTI. But hypertension per se does not contribute to any, has got nothing to do with urinary tract infection, pregnant or non-pregnant, right? So that's your answer here, right? So that's your answer here in this question. All right, Janani, you're rightly answering that question. And let's see the final question of the day. A woman comes for her ANC checkup at 14 weeks. She has increased frequency of micturition. There is no dysuria. Note, there is no dysuria or complaints of vaginal discharge. Pulse rate is 90. BP is 100 by 70. Urine routine examination shows albumin of 1 plus, some 6 to 7 pus cells per high power field, and nitrite positive on dipstick. All are true except. What is the not true statement? What is the not true statement? She has increased frequency of micturition. That's a physiological change. Right now, she has no dysuria or urinary complaint. So she is having what we call as asymptomatic bacteriuria. She has pus cells in the urine. She has some little bit of protein also in the urine, which is suggestive of infection. Nitrite positive also signifies the presence of bacteria in the urine, right? So she's having asymptomatic bacteriuria. And Janani, you are rightly saying that all are true except what is not to be done. What is the wrong statement here? Asymptomatic bacteriuria need not be treated. This is the wrong statement. So empirical antibiotic treatment can be started. That's a true statement. And most of the times the drug of choice that we use is nitrofurantoin. Okay, most of the times the drug that we use for empirical antibiotic treatment is nitrofurantoin. I did tell you that if left untreated, this asymptomatic bacteriuria can progress to pyelonephritis in about 25% cases if left untreated. So we need to treat asymptomatic bacteriuria in pregnancy. And most common organism responsible for urinary tract infection, I mean, non-pregnant or pregnant, it's the same. It's E. coli, right? So that's also your true statement. So the wrong statement here is asymptomatic bacteriuria need not be treated. That's wrong. Asymptomatic bacteriuria should also be treated in pregnancy. And that is exactly the reason why urine routine microscopy and culture is a routine investigation in pregnancy. Right? So that's been my time, guys. Thanks for listening. So for today's session, we had a comprehensive understanding of what the changes are. Please do not forget that all our systems are interlinked. Okay, so one change leads to the other change. One system change is compensated by some other system change. So if you're going to have a wholesome picture of the changes or physiological changes in pregnancy, more likely that you'll remember it in the longer term. And do not get hassled by this topic. I know there can be a lot of increase, decrease, same and everything, but just remember, hold on to your concepts tightly and it should help. So today we talked about the cardiovascular, the respiratory system and the renal system. Tomorrow's session I'm going to talk about the metabolic changes in pregnancy, like iron metabolism, calcium metabolism, thyroid metabolism, carbohydrate metabolism. So these metabolic changes and some important questions I'll discuss tomorrow. And as far as the special classes are concerned, they are free classes, special classes, free classes. You can join me there. Today I'm going to talk about clinical manager breach presentation, 8th September, 8 p.m. And tomorrow I'm going to talk about other malpresentations, and then obstructed labor is the next session upcoming. This is on the Unacademy platform. These are special classes, free classes, so you can join me there as well. Otherwise, I'll see you same time tomorrow, 4 p.m. for the part 2 of maternal adaptation. So hit the bell icon for notifications, subscribe to the platform, and if you want to subscribe, you can use my code, that is SHONALI, and avail a 10% discount on your subscription package as well. So thank you so much, guys. Have a great day. See you tomorrow. Bye bye. Take care.